My name is Alisson and I'm going to talk about diuretic treatment in heart failure. What is heart failure? Heart failure occurs when the heart muscle is weakened and cannot pump enough blood to meet the body's need for blood and oxygen. Warning signs and symptoms: shortness of breath, chronic coughing or wheezing, edema, fatigue, nausea or lack of appetite, confusion, increased heart rate. Causes and risks for heart failure. The most common conditions that can lead to heart failure are coronary disease, high blood pressure, and previous heart attack. Okay, here's video. Common heart failure medications: ACE inhibitors, captopril and enalapril, angiotensin II receptor blockers, losartan, valsartan, beta blockers like bisoprolol, metoprolol, carvedilol, aldosterone antagonists like eplerenone, spironolactone, and diuretics like furosemide and bumetanide.
In the early stages of heart failure, the patient might not even have symptoms, and they might only have risk factors for heart failure. This means that they probably have some kind of pre-existing condition that might, if you leave it unchecked, lead to heart failure in the future, or lead to worsening heart failure if it's already present. But these conditions haven't led to full-blown heart failure with symptoms, so patients are likely still able to go about their daily lives. Some example risk factors might include something like hypertension or high blood pressure, or coronary artery disease, or diabetes. The doctor might recognize these conditions as red flags for heart failure, and even though they're just seen as these preliminary signs and risk factors, they'll emphasize the importance of improving these conditions before heart failure gets worse. Because most of the time, especially with structural changes to your heart, where it starts to look different, these tend to be unidirectional, meaning that those changes only tend to get worse, not better. So with that said, a very important early stage treatment that's recommended is exercise. With exercise, your cardiovascular fitness increases. This increases your heart's efficiency, so your heart gets better at pumping blood. And we know that a reduced pumping efficiency is a main theme in heart failure. And in addition to exercise, another lifestyle change that might be recommended is a change in diet. And reducing salt intake is a common and important change. And doing this tends to reduce your blood pressure, making it easier to pump blood out. and this lowers the chances of the heart to start to compensate and start making structural changes to the heart's ventricles, which, like we said, is a one-way street. The doctor might also decide to prescribe medications, and these will often be targeted at reducing blood pressure, which, like we said, makes it easier for the heart to pump blood out and reduces the chances of compensation and structural changes to the heart. So the first class of medications are ACE inhibitors, or ACE inhibitors. This stands for angiotensin converting enzyme. And these are vasodilators. And from this word we've got vaso, which means vessel, so your blood vessels, and then you've got dilator, which is to widen. So these cause your blood vessels to dilate or get bigger. And when they dilate, they aren't squeezing the blood inside them as much, and so the pressure in your blood vessels goes down. And if the pressure in your blood vessels goes down, your heart's going to have an easier time pumping blood out to this lower pressure system. Just remember that analogy about trying to blow air through a really small straw and then a really big tube. Which one's more difficult? It's the straw, right? Well, in the same way, your heart's going to have an easier time pumping blood through these dilated blood vessels. And another set of medications that might be prescribed are hydralazine and nitrates, and these also tend to reduce your blood pressure. Hydralazine specifically acts as a vasodilator for arteries and arterioles, which are the blood vessels going away from the heart, right? And like we just mentioned, this makes it easier for your heart to pump blood out. Nitrates, on the other hand, although they can act on your arteries as well, mostly act in your veins. So they act to reduce your venous blood pressure. And this reduces the pressure in getting blood back to the heart, which also reduces your preload. Remember that the preload is one of those mechanisms of compensation. So if we reduce the preload, we can limit the structural changes that might start to happen as a result. Finally, the last class of medications are called beta blockers, and these help inhibit the activation of the sympathetic nervous system. Remember how the sympathetic response in the heart is activated with these receptors on the heart? Well, these receptors are generally known as beta receptors. So beta blockers tend to block these receptors from being activated. That makes sense. So if they were activated, the heart rate and pumping force increases, right? But if they're blocked, this tends to slow down the heart rate and limits that sympathetic response. And limiting this is important because just like increased preload, we remember that overactivation of the sympathetic nervous system is a method of compensation, which can lead to structural changes to the heart. And so we want to try to reduce the chances of any structural changes.
Now, diuretic treatment in heart failure. Most accepted pharmacologic treatments for heart failure are supported by evidence from large clinical trials. In contrast, evidence from large, well-controlled clinical trials to guide the use of diuretics among the most frequently used drugs in heart failure is generally lacking.
Heart failure causes fluid retention or congestion in your body and lungs, which is responsible for many of the symptoms associated with heart failure, such as shortness of breath, ankle swelling, and loss of appetite. Diuretics are used to reduce fluid retention and congestion. They act on the kidneys, causing them to eliminate more water and salt and increase the volume of urine. By removing excess fluid, diuretics reduce the volume of blood circulating, which lowers your blood pressure, lowers resistance, and reduces congestion. This makes it easier for your heart to pump blood around your body and improves your symptoms, especially shortness of breath and the other symptoms of congestion.
How it works. Diuretics stimulate the kidneys to remove more water and sodium from the body. This can help relieve swelling that happens because of heart failure. Side effects: loss of appetite, stomach, nausea, dry mouth or increased thirst, hives, confusion, and muscle cramps or pain. Pharmacologic characteristic of loop diuretics. Furosemide, bumetanide, and torsemide are prototypical loop diuretics. These agents bind to the translocation pocket at the extracellular surface of sodium-potassium chloride cotransporters. Blocking ion transport directly, loop diuretics inhibit the NKCC2 at the apical surface of thick ascending limb cells along the loop of Henle. This transporter reabsorbs up to 25% of filtered sodium and chloride. Its blockade is responsible for most natriuretic effects of loop diuretics.
Loop diuretics are the most powerful class of diuretics. The main drugs in this class are sulfonamide derivatives. Loop diuretics action is described as a torrential urine flow. Loop diuretics act on the thick ascending limb of the loop of Henle. The thick ascending limb is the main site for active sodium reabsorption. On the luminal membrane, the transporters involved are the sodium-potassium chloride cotransporter and potassium channels. On the basolateral membrane, the transporters involved are the sodium-potassium ATPase, potassium channels, the potassium chloride cotransporter, and chloride channels. The sodium-potassium ATPase drives active sodium reabsorption by moving free sodiums across the basolateral membrane into the interstitium in exchange for 2 potassium ions. Potassium is returned to the interstitium through the potassium channel and the potassium chloride cotransporter. This creates a deficit of sodium inside the epithelial cell. The sodium-potassium chloride cotransporter is activated to restore this deficit. The cotransporter NKCC2 moves 1 sodium, 1 potassium, and 2 chloride from the lumen into the nephron wall. Potassium goes back to the lumen through the potassium channel. Chloride moves to the interstitium through the chloride channel and the potassium chloride cotransporter. Loop diuretics block the sodium-potassium chloride cotransporter. This prevents sodium and chloride transport across the luminal membrane. The reabsorption of sodium and chloride in the thick ascending limb is blocked. The result is greater excretion of sodium, chloride, and potassium in the filtrate and their reduced levels in the blood.
Loop diuretics also inhibit the same symporter at the apical membrane of macula densa cells, stimulating renin secretion and inhibiting tubulo-glomerular feedback, which normally suppresses glomerular filtration when salt delivery to the macula densa increases. These two additional effects may be both salutary and harmful because elevated plasma renin activity increases the level of angiotensin II, whereas blocking tubulo-glomerular feedback helps to maintain the glomerular filtration rate. When administered intravenously, loop diuretics cause vasodilatation in part by inhibiting the NKCC1 in vascular smooth muscle cells. NKCC1 is also expressed by cells of the afferent arteriole and in the extraglomerular mesangium, where it suppresses basal renin secretion and generation of angiotensin II. Thank you!